Equity's Role in Social Determinants of Health Interventions. This is a webinar series, and we were focused on implementation. I'm Artia Rogers, the Director of Programs for California here at Health Week, and I'll be moderating our discussion today. But before we dive in, I'm going to have Ola go over a few housekeeping items first.
Hi, everyone. Like Archer said, welcome to the Q&A session of this webinar. So can you guys take a second to make sure you guys have the following panels open? Please click on the participants panel so you're able to see all that are called in, and then click on the chat panel so you're able to chat to each other and also to the panelists. And if at any time during this webinar you're getting any audio issues, please click the three dots for the audio connection issues information, and you guys will be able to see calling number, the event number, and your attendee numbers. The chat function is at the bottom right of your screen. And when you're chatting, please make sure to select all participants so everyone can see your wonderful questions and suggestions. And if you're experiencing any technical issues at all, please send a private message to the Learning Network. Attendee, if you have any other issues, you can also click the raise hand button, which is also at the bottom right side of your screen. And if at any time you want to come off mute, please click the speaker button, and you will be able to come on and off mute. And just a reminder, this webinar is being recorded, and we'll share the slides and also the recording afterwards. So just so everyone could test their chat function, can you please chat into all participants what the weather is like where you're calling in? Looks like everyone is able to locate the chat function, and great to see a lot of sunny. I'm really jealous. It's cloudy over here in Chicago, so really jealous that some of you are getting a lot of sun.
For those of you who are new to Health Leads, we are an innovation hub that runs both national and local initiatives that really address the deep societal roots of racial inequity that impact our health. Through this work, we partner with others to share learnings and create spaces of inquiry centered on equity in healthcare, especially when it comes to integrating social care into clinical care delivery. After the Equity's Role in Social Determinants of Health Interventions, the implementation webinar, we heard from a lot of you that you wanted more time to discuss this topic with our panelists, and so we're really excited to be able to continue our conversation with you today. We can answer your questions and discuss how we as a community can elevate and create practices focused on intentionally integrating equity into social need interventions. During the webinar, we heard from 4 panelists who are in the trenches using social care to advance health equity for historically underinvested communities. So joining us again today is we have Leticia Reyes-Nash, the Director of the Office of Programmatic Services and Innovation at Cook County Health. At Cook County Health, Ms. Reyes-Nash also serves as the co-lead for the Center of Health Equity and Innovation. Her current projects focus on addressing social needs, specifically housing, behavioral health, advocacy rooted in justice, and food security. Next, we have Mariah Moini, the Director of Programs for the Los Angeles County Department of Health Services, the Women's Health Programs and Innovation Department. In her role, she leads a variety of women's health initiatives, including Mama's Neighborhood, which we learned about in the previous webinar. Mama's Neighborhood is a multidisciplinary mother-centered program that begins at pregnancy and supports the mother, baby, and family up to 18 months postpartum. Mama's Neighborhood has been replicated throughout the county and is integrated into the criminal justice system. Next, we have Ms. Nimisha Patel, the Associate Vice President of Management Services at Duke Health, Private Diagnostic Clinic, PLLC. In her role, she leads and directs programs and initiatives to enhance the patient and provider experience across Duke's collection of outpatient services. And finally, we have Tigee Hill, our National Director of Partnerships and Initiatives here at Health Leads. In her role at Health Leads, she uses her extensive experience in implementation management and program evaluation to assist institutions in assessing, designing, and implementing social needs interventions. So before we go into the Q&A, we thought that it would be helpful to do a quick recap of how our four experts are intentionally integrating an equity orientation into the way they have implemented social needs interventions, particularly in regards to screening and navigation or connection to resources. So first, our first presenters were Nimisha and Tigee, who emphasized the necessity of creating social need interventions with communities rather than for them, because community members know the needs facing their communities better than we do. They also stressed the importance of involving and training all staff in cultural humility, implicit bias, trauma-informed care, and inquiry that focuses on empathy to increase comfortable interactions with community members and decrease any unintentional harm that may come from inquiring about social needs. And ultimately, they really showed that communities know what's best for their people, including them as partners, and decision-making leads to a more equitable design and a program that is highly adopted and utilized because it meets the specific needs of the community. And they really use a great case of being able to use community feedback to shape screening questions focused on racism. The next presenter, our next speaker, was Leticia, and she reminded us that navigation efforts should be both resource-based and policy-based. In order to have long-standing success, we must design to inequities and the root causes of those inequities, which are the societal inequities, institutional inequities, living conditions, and risk behaviors that may prevent people from connecting to a resource in the first place. She highlighted the need to operationalize the business of health equity and include it into organizations. She touched upon the importance of this when it came to responding to the coronavirus. As COVID-19 has exacerbated disparities, equity is a necessary requirement across sectors since social needs intersects with the individual, community, and even at the policy level. She had a great quote where she said, "Systems fail people, people don't fail in systems," and we need to think about how we need to keep that in mind as we seek to fix the system failures and hopefully successfully serve our communities in a more equity-oriented fashion. Our final panelist, Mariah, shared how the integration of social care and clinical care can be used to tackle disparities. She shared how important it is for us to understand how social need interventions can be used to address discrimination and also perceptions of discrimination perpetuated by the healthcare system. As health services, it's our job to remove barriers that are structurally oppressive. We must think through how do we diversify the skills of our team. To really ensure well-rounded care, it is just as important to have heart-centered providers as it is to have folks skilled in maintaining partnerships. She also mentioned that viewing services with an equity orientation. This is really how we understand how race and place can impact health outcomes. Having this orientation will cause a shift in care that is focused on the well-being of the patient. And with that, I think we're going to start with our discussion. I want us all to be mindful that as presenters and speakers come on and off, we're all, living in a time, living in the COVID pandemic, and it's impacting us in different ways. So please be gracious if you hear any background noise. And as Ola mentioned before, we really want you to be a part of this discussion, so please submit questions in the chat function. I am going to start off with a question. I think there was another note that, as a reminder, if you want to speak, you just raise your hand. Simply click the hand icon on the bottom right hand of your screen. Come off mute, and we'll click the speaker button you see. And if you're submitting questions, as I mentioned before, just please put those in the chat box. So there's two different ways for you to interact in the conversation: raising your hand or submitting questions via the chat box. So I'm going to start us off with a pre-submitted question, and this is open to all of the panelists. The question that I have for you all is, does the healthcare industry not find the moral imperative for equitable outcomes enough of an imperative for our population? And I think that question really goes to the heart of, is the moral imperative not enough for the healthcare industry to act on having an equity orientation? So would love to hear your thoughts on that.
So, Artir, can you hear me?
I can hear you now.
Okay, this is Leticia. I can take a stab at starting to answer that question. I think for the health system that I work at, which is Cook County Health, and we are the safety net provider in Cook County, and I think that it's part of our core mission to serve everyone regardless of their ability to pay. That's been our mission for 180 years. In my experience, working pre-COVID-19, we have been working to get investments for various projects, but one of them is around housing, and we have a collective action model around housing, and we're working on getting various investors to be part of that. And in that experience, we found that that we had to be able to have the business case with the moral case. And so we've been working hard to engage other hospital systems in making those investments, and part of that has included both strategies and both communications from those who are already invested in this work, but also to help build the collaboration. So it's been both before COVID-19. I think that, as we're living in a COVID-19 world now, I think that it's different than having these conversations pre-COVID. And I think that we all have to kind of reflect on how the various systems are working or not working for us in COVID-19. And I think that we have an opportunity to reframe the conversation around addressing social needs and having stronger relationships with other sectors to be able to address health not only as an individual, from an individual perspective, but also from a system perspective. So I think that we're moving to an opportunity to, I think we're moving away from only having to having maybe both. It's almost like the business case and the moral case are just merging. And I think that we'll have opportunities to kind of talk about how these social needs are being met in a different way now, and then, hopefully post-COVID.
This is Mariah. I can add on to that. I would say that's a really kind of strong question, and I agree with the fact that fortunately or unfortunately, we do need business cases that pair with moral ones, or ones that are directly related to humanity. And the reason is because so much of what we invest in is questioned by so many different entities, and things are so interconnected, again, for the better or for the worse. And so until we can have more ecologically friendly conversations that really connect the different sectors and I guess it would be different sectors and different investments, and we have the discussions that are related to how they're interconnected, then we can start to understand and start from, like, first base to be able to have those discussions. The other thing is when you're dealing with institutions or, again, one entity that might be forward thinking, sometimes systems are so antiquated and the vision is kind of lost through the game of telephone. And it gets reinterpreted so many times and not revisited. And, without that, and without, again, the philosophy that things are very much interwoven, it's very hard to just make the moral case, because then you come off as deviant and flippant and not grounded in any sort of hard science, and the business aspect of things, the utilization of aspect of things. So by placing those together and adding the voice of actual participants and stories and collecting of qualitative and quantitative data that positions equity as important, then you can make the case. So I would argue that it's a business case as well as almost an evaluation or programmatic case that positions the voice of the recipient or the end user. That's really important to make the moral case. So
I love that. This notion of we're in a world where, as Leticia was pointing, that the business case and the moral case are colliding. But as we're thinking about the business case, Mariah is also talking about uplifting the narratives of the end user. And that's how we can promote an equity orientation and how we're doing this work. I'm hoping that I'm receiving that information correctly. I wanted to see if Tigee, you or Nimisha, you have anything to add to that?
Yeah, so hi everyone, this is our chair, Leticia, and Mariah, thank you for providing some context and response to the question. I agree with all of those points, and I think where I would like to give a little bit of a different lens or an additional lens is from the healthcare system setting. So I've had the chance to work in the Southeast United States, particularly in North Carolina, and have worked for two major healthcare systems now, both at UNC Healthcare and Duke, working currently at the Duke Healthcare System. And both organizations have definitely demonstrated, being here for the community and for all North Carolinians and beyond, especially at Duke. We have a patient base across the nation and globally. However, now speaking more generally and as a direct response to the question, I don't think we're a complete yes. So for me, that the healthcare industry sees equity as a moral imperative. So for me right now, the answer is no. It's certainly happening in an exemplary way in pockets, but I don't think we have reached that kind of widespread point yet, and that it's at the tip of our tongues, or equity is embedded in all of our templates that we typically use when we're thinking about healthcare and the strategy of healthcare and the operations of healthcare. And again, speaking from my perspective, I think there's just some basics that we have in place right now that doesn't get us to that natural place of, well, maybe not natural, but that place of, yes, hands down, this is a moral imperative. And one of those kind of fundamental aspects is the healthcare system. I'm speaking again from a healthcare system perspective. Leadership. If we look at the leadership at most healthcare systems in the Southeast, they are currently filled by a very homogenous group who has, mainly not really had to think about equity or haven't had lived experiences where they've had gaps in their ability to access certain things. Now, I know that's a generalized comment, but that is what I have seen. So I think that's one really basic element that acts as a barrier for it to be raised up as a moral imperative. And really, the current state, we have to sort of lead with the return of taking an equitable approach. And so that, I think, for me, raises even another question that we should be asking is whether, I think we haven't really taken a deep dive into the question of whether health is a basic civil right to be treated as a public utility, or is it a private commodity that's only available to the groups of people to the extent that they can afford it, or they have access to it, or have been employed by an employer who can provide health for them through the vehicle of health insurance. So I think it raises even a deeper, this question around a moral imperative, to me, spins off another question about is health something that is a civil, a basic civil right, or is it more of a private commodity? And I'll leave it there.
Thanks, Nimisha. I'm so sorry. Artera, this is Mariah Moini. I would like to second that, but to add something to that, when you move to the question around, healthcare as a commodity or not, I think as we move on in this discussion, a lot of why we're asking and having these discussions around disparities for many decades now is really centered around blaming the victim. It's very, very easy for an individual, a community, a system, and then at the federal kind of policy level to turn away and to shift blame on a person or a group of individuals rather than to reflect and share responsibility. And that's really almost at the very root of not just this issue, but any issue that we have in the United States or a global policy. It's very hard for humans, I think, in general, to take moral responsibility for things outside of themselves without thinking about themselves first. There's like a psychology around all of this, and then kind of a community, shared mindset of things that we're tackling right now. And I think, Leticia and Nimisha said this very, very clearly around what's happening with COVID, is that it's testing us, it's pushing us to ask the very hard questions around what we value. And I would agree that leadership and value must be aligned. And before anything really can change, unless there is a large enough base and body of collective, very articulated mind from community that mobilizes and then, forces a conversation on this. So.
Yeah, I really appreciate that perspective that both you and you, Mariah, and Nimisha have given, really thinking through our values and how that's displayed. I would like for us to even move the conversation more tactically. There's another submitted question that focuses on just recommendations of how to expand social need interventions from the individual level, which is screening, providing resources, and data collection to more of the community government and policy level. And I think that this is something that Leticia touched on in her presentation. But I'm just wondering, how can we, I think the person who's posing this question, we want to know what recommendations you have for organizations to align the work that they're doing at this individual level with more of the policy, community governmental work. So I guess starting off with Leticia, because I think that question was directed at you, and then Tigee, since you were not able to respond to the last question, wondering if you wouldn't mind, being queued up next to speak about any recommendations you have from your perspective, if you have something to add.
Great. So I think, I talked to yesterday to a group of primary care physician fellows, and the similar question came up around, around how do you link, the work that you're doing in a programmatic sense, or your individual interaction with a patient, how does that connect to all of the different levels, and how do you work, and think about this from a policy level? And I think that as I, in my experience working with the clinicians that we work with in our health system, a lot of clinicians have a lot of frustration in what they're doing at the clinical level when they can't impact so many elements of their patient's experience. And so when we've started to do the work, we've been doing this work for many years, but as we've been more vocal in communicating the work that we're doing around helping individuals who are experiencing homelessness, and working on, those who are experiencing, substance use disorder, and those who are justice involved, as we've been building and communicating more about the work that we're doing, both at the individual level for patients as well as the policy level, it's been really, I'm trying to think of the right word. It's felt for clinicians a lot better to understand that we're working at multiple levels, and also not only looking to identify individual resources for these patients, but also understanding that we're sitting at the tables where policies are being discussed. We're investing time at understanding how do we engage with system partners that could be creating barriers for our patients, and really understanding that advocacy is part of what our health system's job is, in addition to doing the clinical care. And so if you look at our strategic plan, we have, health equity is one of our strategic priorities, as well as advocacy. And I think that that as we've continued to do this work, it feels, while, we're not solving every issue and we're not solving every policy problem, at least we're not sitting quietly while these different conversations are happening. And I think that from a clinical perspective, we're bringing some additional resources at that level, but they're also, being heard. Our clinical providers are being heard, and our patients' needs are being heard as we're communicating in those other levels. And so I think it's a long game. And so thinking about how you're doing this work and how you're layering your approaches, I think is really important. But I think that we as a health system have some obligation to use our power and privilege as a nearly $3 billion organization to be able to communicate at those levels and sit at the tables and and advocate for what our patients need from a systematic level, as well as providing the clinical care that we do.
Thank you so much for that, especially the notion of using institutional power and privilege as a way to advocate. Tigee, just wanted to bring you into the conversation if you had anything to add around that, but totally okay if you.
No, thanks, Marcia. I appreciate it. So just a couple of things that I'll add. I agree with everything that's been said so far. I think a big opportunity is building the relationship with community and with other organizations that are focused on advocacy. A big piece of taking an equitable or being more equity oriented is relinquishing some power. And to Leticia's point, a lot of healthcare systems, the healthcare industry has a lot of power. And one thing that we've heard in doing a lot of our work is one of the challenges that community organizations and community residents have with working with healthcare systems is an unwillingness to relinquish that power and work with them equally in decision making. Another thing I want to point out is the importance of approaching diversity, equity, inclusion that work at a system level. We've worked with a lot of different health systems where it's articulated as one of their values. It could be a part of their strategic plan. I've worked with healthcare systems where they have received awards for their commitment to diversity and inclusion. But when we work with these systems, we only see it in pockets where they're, sorry for the background noise, we only see it in pockets where there are certain departments or certain teams that are really focused on working with the community, taking an equitable approach, looking at diversity in hiring, but we don't see it across the system. And so in even understanding what needs to happen, the victim blaming, all of the things that were mentioned before, we don't see that across the entire system, and particularly at the top, as Nimisha mentioned, where it's more homogenous, it's not getting represented where the decisions are being made. And the lived experience isn't appreciated, which is another huge barrier that I've noticed in being able to, pull this through from just screening to a more institutional and systemic level. So in summary, and sorry about the rambling here, I think it's important to make the effort to make sure that these are values throughout the entire system and not just in pockets, that lived experience is truly valued and that voice is brought to the table, and that we're not prioritizing, just the clinical or academic perspective over lived experience.
Love that, Tigee, just with honoring the lived experience, making sure that we understand, kind of going back to what Leticia was saying, our institutional power, and sometimes we have to relinquish that power in partnerships. And one way that we could seek to do that is in partnership with community advocacy organizations. Really appreciate kind of the recommendations on how we can really start aligning our kind of individual level work to more policy advocacy type of work. I wanted to remind everyone, and I hope I haven't missed the chat, if you have questions, please submit them in the chat, or feel free to raise your hand and come off mute and ask your question. Okay. That's definitely available to you throughout the entire time. I am going to move to another kind of more tactical question. There is a lot of questions around tools and resources as you all were talking. There was a question around, are there tools or what resources or how do we start detecting implicit bias in screening tools or trainings to help us to recognize implicit bias in our screening tools, and even the way we do navigation. And Mariah, there was also a request to understand more about the experiences of discrimination tool, and are there other tools like that that people can use to start to get that data point of that lived experience that Tigee mentioned earlier around people's experience with discrimination and racism. So, yeah, just would love to hear everyone's thoughts around tools around implicit bias for screening and for navigation, but also hearing more about the experience of the discrimination tool, Mariah, as well.
I can kick us off right there. Can you hear me?
Yep, we can hear you.
Okay. So a lot of what we discussed during the webinar, I think plays well into ensuring that we are presenting questions in our screening tools that aren't rooted in implicit bias. So again, as I mentioned earlier, making sure that we're taking an organizational approach to training and arming our teams with not only recognizing their biases, but being able to have alternative thoughts or ways of dealing with that bias when it does come up. Pieces, that we discussed about making sure that the screening tool is accessible, that, it's in the appropriate language, making sure that we're not using offensive language when we're referring to our patient populations when we write the screening tools. The reading language, again, the lived experience. So bringing that perspective as we're building the screening tool, having input from the community will be particularly helpful in making sure that we're building a tool that's culturally sensitive and that the population that we're screening, that they're comfortable with and that they can understand.
Thank you for that, Tigee. Anyone else want to build off of that?
I do want to raise awareness based on what Tigee said about collecting lived experience and enrolling community members, whether stakeholders and residents, into the process of designing that screening process that we talked about during the webinar. Sometimes you will learn information, and it's likely, because that's the whole point, is that we have a gap on the professional side as decision makers and people who hold power with the decision-making structure. We don't have the same lived experiences as the residents in the community do, and we may to a certain degree, but oftentimes we will collect themes by having focus groups or key informant interviews with members of the community and people living in a certain place. Those themes may not necessarily be ones that we understand. Like what people may ask for is something that may be completely counter to the way we've approached things when it comes to developing workflow or developing a screening process or a questionnaire. It may just be completely counterintuitive to us, but that doesn't mean that we can kind of, in my experience, I have really challenged myself and challenged teams that I've been working with just because a theme surfaces that is really going to fundamentally shift the way we're doing something or asking something, or it doesn't necessarily fit very squarely and neatly in our own mental model, that we don't kind of save it for later or put it off into a parking lot somewhere because it just really stretches our mind too much that we aren't able to move forward with it. So I do want to kind of give that type of heads up that when I have done the work around collecting lived experience voice, oftentimes there will be themes and learnings that are ones that the professional side may just not simply understand.
Thanks for sharing that, Nimisha. Really challenging us on the importance of collecting lived experience because it may shift some of our models of how we approach care, particularly social need interventions. I think that is something that we all should really hold on to and be intentional in collecting lived experience. I would like to see if Mariah could speak a little bit more around the experience of discrimination tool and, really talk about what the tool is and what your organization is hoping to do with it.
Sure. And just to chime in on what others have mentioned regarding how to include that and why to include it. Number one, I would say I agree with testing it with your population that you're working with. I think that's, kind of a standard in many different sectors to see how it's received or not received and see if it's actually a reliable tool or reliable question in being able to ascertain what change you're looking for. I think also integrating, number two, I would say integrating behavior change theory and different, there are different models that and theories of change that can help a program or a system construct something that takes into account the behavior change that is necessary for a person to make to move them closer to a readiness to change. Similarly, I would conversely apply that to the system. So as you're taking, let's say, a proceed model, that is a behavior change model, you might take that and apply it to your system and then also apply it to understanding the individual levels of readiness to change in for the patient or the mom or the dad or an adult, individual. Another one to look at is the trans-theoretical model of change or stages of change. That's something that's really salient and resonating right now. That's similar, another behavior change theory that's been used and tested in many different arenas to help understand how a system might or might not be ready to change and what the base level of values are, and to recognize them, honor them, and then be able to figure out what small wins will help a system or a person move from one rung of that change to the next. I would also, as you mentioned, Artera, is looking at experience of discrimination. There is a scale, and that's exactly what it's called, experience of discrimination. So if you put that into Google or Google Scholar, or if you have access to academic libraries, you can certainly go on to PubMed to look for that particular scale. There's also one called the perceived discrimination scale. There's, I believe, another one. That is. There's a very large document that talked about several different scales that that measure discrimination, and I think one is called the Everyday Discrimination Scale. There's a Major Experiences of Discrimination Scale. There's a Work Discrimination Scale, Heightened Vigilance Scale. And many of these, some of them even are linked to coping and internal, external locuses or loci of control, which is, usually affected when you're talking about discrimination or racism. And so in having these first discussions, I think if a system or a policy advocate or an equity department took these scales and approached it incrementally in a way of, hello, leaders, here are several scales that might help us begin the discussion. Which one do you think resonates well with you and why? And talk about what this, do a SWOT of that sort of experience with either your staff or with a system if you can get in touch with them, or a local government official like a health deputy of your local government, and start a little bit of a discussion, and know that it's not going to be like a jump, if you're looking for change. I think the other thing to align it with when you're looking at discrimination or racism scales is to think about the flip. Many times in business, they're thinking about what is the end user thinking. They're always trying to make sure, and for profit reasons, right? But the concept of understanding it from the other person's point of view is really important. And since we're in public health, it becomes more of an empathic approach that we're trying to take. And, or if you're coming from a business perspective, you're trying to map out and understand how the end user is going to be utilizing your system, and how are you going to help navigate that so that you're reaching your, meeting prime metrics, for example, or other metrics that are out there, as well as saving money. So going back to what Leticia said in the beginning regarding a business case, when you're looking at this, you can't just introduce something from a moral perspective. And so what we have done in this case is, because we got a Healthy Start grant, and because our Department of Public Health, I'm part of Health Services, our Department of Public Health put out a strategic plan that called out racism as a predictor for many different disease orientations. And because our Board of Supervisors, which govern Los Angeles County, have been talking about this and calling it out, it was a prime opportunity to introduce this and have it be palatable for people. If you're not in that case of being palatable, I recommend going back, doing a scan of what is out there, getting the data on that, and saying, well, it was, shown here in this very diverse sample population to be correlated with, poor, let's say, birth outcomes. By having an experience of discrimination or racism, it led to poor birth outcomes or intergenerational traumas. So, being able to show that data and then link it to the business case and say, people go where they feel they have a relationship. And if they're not heard and they don't have a relationship, they're not going to use you. So then they're not using you and you're not making money. So think about it from that perspective and draw the plan for them and the link for them so that they can start to feel what's palatable. And if it's not palatable for them, ask them why. Don't assume, don't walk away. Ask them why and say, what's really at the root of this, and maybe I'm wrong. Pull it back to yourself and say, you know what, maybe I'm coming at this the wrong way. Can you help me understand where your priorities are right now and what is most comfortable for you? So it's like, again, that back and forth, almost a sales approach to having the conversation about where they're starting, or whomever you're trying to move, in terms of having this conversation around equity.
Thanks so much for that, Mariah, especially, the emphasis you're putting on testing things out, getting that feedback before, you introduce a scale, even though we have all of these great tools out here, really testing and seeing how it resonates with the end user. It's particularly coming from more historically underinvested and under-resourced communities that should be uplifted. I wanted to pause one more time to see if there is a question from any of the attendees today that they would like to throw out to the panelists. All right. So there are two questions that I'm going to try to fit in. So I may have like a couple of you talk about one, and then the other group talk about, the remainder of you talk about the second question. And the reason why is there was a lot of conversation around partnerships clinical partnerships, public-private partnerships. And, I think it could be just really helpful if one or two of you really discuss how do you assess if a partnership is promoting an equity orientation when it comes to social needs work. Like, how do they identify what partners they should be working with, and how do they know if it's the right partner for them? So I'm going to ask, one or two of you. I would love, Leticia, you talked a lot about partnerships. I think that, it'll be great to hear your insight on this, but any one of you, Nimisha, just, really delving into that question briefly if you can, so we can talk about one more topic.
I can briefly start. I think I think the question about ensuring equity in partnership is a good question to ask, and I think that there is a lot of history in community around partnerships that do not have an equity priority, and so I think that it's a critical piece, and I think one of the core components in effective partnership is trust and relationship. And things can look great on paper, but if you don't have the foundation of trust and relationship, it can be very challenging. So I think those are two elements that sometimes get undervalued when going into partnership, and I think that that's something that an entity, or you can partner and say, okay, you're going to get these resources and these funding, or this is your role. How are we going to co-create this and create the role? But you can't even get to the conversation of partnership if you don't have the trust and relationship there. So I think that's a critical piece. And then I will just note that there is a group of hospitals in the city of Chicago who have been working together on a project which we call Westside United. And I think that you can look further into that model. Our health system is one of the health systems that's part of that partnership. And the Westside United model is a very robust model that focuses on a group of communities in the city of Chicago to address issues of equity, and working to partner with the various health systems to do that. And they have a very intense community voice that is part of that model. And it has been it's been built over the last several years, and has been a really critical resource as COVID-19 has come about to help. Again, that trust and relationship has been built over several years, and has been able to be activated and leveraged. And again, I think that one of the important components of that partnership and that group has been around fostering and building and the relationship, but also ensuring that community voice is part of that infrastructure. So that's a group that I think, and a project that I think would be helpful for folks to look at as a model.
Thanks for doing that. And I know I said I was going to allow someone else to come into that part of the conversation, but just for the sake of time, and this is how we're going to end the Q&A for today. There were a lot of questions around, is work like this published, and where can we find it? So it shows that there's sometimes a gap of sharing knowledge around intentionally integrating equity, particularly in social determinants of health interventions. And I'm just wondering if I could hear from all of you briefly just how we can continue sharing knowledge, like what are the ways to do that, and would love to hear from you, as many of you as possible. So whoever wants to take a stab at that first, that'll be great.
This is Mariah. I can go quickly. I would say one method could be if you are comfortable, Arter, we can send you a library list of articles that we could and that I have used that have been helpful and having these discussions with different leaders. Some of the particular people that I've been looking at regarding equity and MCH issues around preterm birth have been Kamara Jones, David Williams, Monica McLemore, James Collins. There are a few more, and there's actually a lot on this, and there's a whole race and equity, and ethnic disparities compendium that was written many, many years ago that would be, I think, a good place to start also. So maybe we can create that library and then make that available to people. I'd be happy to contribute what I have on that.
That sounds amazing, Mariah. Yeah, we would love to send this out, send those resources out as we send out the recording of the webinar, of this Q&A version of a webinar. But yeah, would love to hear from Nimisha as well as Tigee, bringing you into the conversation of just how we can promote this knowledge sharing. I also, while that's going on, if we could pull up the poll so we can get some of your feedback, that would be great as well.
I can go quickly. This is Tigee. Some things that we Health Leads do as an organization to promote knowledge sharing is, one, elevating the work that's happening in various communities and with different partnerships so that folks across the country can learn from that. Sharing resources that we find, creating collaboratives and having calls where we can bring folks together to share and learn from one another. Getting back to the lived experiences, one of the things that we've learned is there's so much innovation and so much great work happening in communities that many don't hear about, or even in health systems. It's happening like real time on the ground, and I think that's especially true given what's happening with COVID right now. So I think, using any of those platforms, would be a great opportunity to continue this conversation and share resources with folks who are interested in advancing this work.
Thank you. And Nimisha, I want to give you the last word, if you don't mind, and I'll close this out.
Yeah, thank you, Arter. I think I would underline everything that everyone has already suggested and mention that sometimes also the richest conversations happen in informal, casual settings as well. So just connecting with people that are on the journey of doing this work as well in casual ways without having kind of a formal structure around it, I think leads to some really great brainstorming, riffing off of one another on potential ideas of how to integrate the work of social determinants of health or the social drivers of health into your respective organizations, and keeping kind of a regular cadence of those casual meetings. So I will close it out with that.
Thank you so much, Nimisha. I just want to thank all of the panelists for their time today. We'll be sending out the recording to everyone and posting it on the Health Leads website. Also, stay tuned for more information on our next webinar in the Intentionally Integrating Equity into Social Need Interventions webinar series, Equity's Role with Systems Change. If you have any questions or would like to learn more about the Health Leads Network, please either send an email to the network@healthleadsusa.org or check out the website. And I just want to say thank you again to all of our panelists and for all of you for participating in this discussion today. Hope you have a great day. Bye-bye.